So, video assisted thoracoscopic surgery is a VATS introduction. The direct vision of thoracoscopic has used for many years, but it, its use was limited mainly to perform biopsies. Indication at first pneumonectomy or lobectomy, empyema, lung biopsy, segmental resection, treatment of recurrent pneumothorax, diagnosis and treatment of the pleural effusion, resection of bronchogenic and mediastinal cyst, esophageal myomectomy and intrathoracic esophageal mobilization for esophagectomy, VATS sympathectomies. So VATS sympathetic nervous system neurectomy, I think it will be the VATS incision. So VATS incision is important. It is performed via 2 to 4 incision measuring 0.5 to 1.2 centimeter in the length allow insertion of the thoracoscope and instruments. The incision location depends on procedure. Now, principle of port placement. This is very important part. The basic principle to position the port high enough on the thoracic cage to have access in the hilar structure. So we have to place it in a manner that it is high enough so that it can come to the hilar structure. So if we color the port in the black, it should be placed something like this or this so that it is high enough so it can access to the hilar structure, so they can input their thoracoscopic instruments, grasper or Kelly or anything it could be to the hilar. So the drainage after operation drainage after operation, at conclusion of a thoracic operation, the pleural cavity typically is drained with one or more chest tubes. Each chest tube is brought out through the separate stab incision in the chest wall below the level of thoracotomy or through VATS port site. The visceral pleura has not been violated and there is no concern of pneumothorax or hemothorax. After VATS sympathectomies, a chest tube is unnecessary, so we don't need to insert unnecessary chest tube in the thoracic cavity. This is our motto or here in the VATS. So the conclusion is undescended where 179. Okay, so it is the end of this VATS thoracoscopic procedure. Now come to the next question, that is childhood tumor. It is also came in the MCPS in January 2011. So acute leukemia, principally ALL, lymphoma, Burkitt's lymphoma, retinoblastoma, teratoma, rhabdomyosarcoma, Wills tumor of the kidney, acute leukemia, lymphoma, it could be Burkitt lymphoma, retinoblastoma, teratoma, rhabdomyosarcoma, Wills tumor of the kidney, Ewing's tumor of bone, neuroblastoma, tumor of the nervous system, and hepatoblastoma. These all are childhood tumor. It is commonly said as oma. Then lymphoma, okay, one oma, retinoblastoma, second oma, teratoma, third oma, rhabdomyosarcoma, fourth oma, Wilms tumor, Ewing tumor of the bone, neuroblastoma, hepatoblastoma. So if we consider the 1, hepatoblastoma, neuroblastoma, rhabdomyosarcoma, retinoblastoma, teratoma, lymphoma. So these all are childhood tumor. Now comes to our another MCPS production, and this is the cancer screening. Screening is the application of the test to detect a disease while it is still asymptomatic. aims and objective to reach the early diagnosis and treatment at an early curable stage, reduction of cancer mortality criteria. There are some disease criteria, some screening test criteria, some screening program criteria. So we have divided in these three criteria. If we consider the disease criteria, natural history must be understood. What is the natural history? How it occurs? It must be understood. The second is sufficiently common in target population. Third is recognizable early stage. Fourth, treatment at an early stage must be more effective than later stage. So these criteria must present in a cancer screening patient. That how the disease occurs, the natural history you have to understand, and it is the target population. In a target population, it is common, and if it is recognized at early stage, must is most effective than later stage, and it is also recognizable at early stage. These four criteria is must to present in a disease. Now the test criteria. The test should be simple and cheap, and it should be continuous, and it should be highly sensitive, ideal 100%, and it should be highly specific, ideal 100%. If not 100%, it should be more in percentage, high positive predictive value, safe and inexpensive, non-invasive, well acceptable to the patient, offered a group agreed to be high risk, easy to perform and analysis. This is very important. Now come to the program criteria. The must be adequate facilities for the diagnosis in those with a positive test. Quality of treatment of screen detected disease must be high. Screening should be repeated at an interval if the disease processed as an insidious onset. Benefit must overweigh physical and psychological harm, because after it is informed to a patient that he is suffering from cancer, he will be in the psychological harm, and as well as he is also undergoing a physical harm. But if it is diagnosed early, it should be more benefited than psychological and physical harm. It is our saying. Now benefit must justify the cost. If it is costly, then the benefit should justify the cost. The screening method are examination of the patient, self-examination of the patient, as for example CA breast, contrast media such as barium, intravenous contrast, and isotopy study, hormone study, human chronic gonadotropin in the hereditary mode, and prostate specific antigen in prostate cancer. So there are disease such as CA prostate, we should go for PSA. CA breast, we should go for mammography as CA 15-3. Here 3 is some like this. If you consider it is what we can see, this is some sort of like breast. So if a CA 15-3 is for the CA breast, and CA stomach for barium study, and CA 72.4, and CA colorectal, flexible sigmoidoscopy colonoscopy, occur blood test, TRE, proctosigmoidoscopy, and carcinomembranous antigen. These all are very important for the CA colorectal. Advantage: the reassurance for those with negative test result, less radical curative treatment, and resource saving. And because if it is diagnosed early, or so there's less curative treatment and so there's cost is less. That is why it is saying that resource saving. Improved prognosis, it gives a improved prognosis, assurance of the good quality of the life in case of screen detected cancer. In case of screen detected cancer, it gives a good quality of life. Now come for the disadvantage: anxiety and morbidity for those who is false positive, because if we do this test, there are some results which may be false positive. This false positive will take out the nice clip of his life. and because of anxiety and morbidity. Not suitable for the rapidly growing tumor, because if a tumor is so rapidly growing, if we can screen a cancer, we can find that the cancer is already in the advanced stage. Risk of treatment of a borderline abnormalities. Selection bias may cause relied cooperation from the population. Resource cost high. So conclusion is application of the screening program is an appropriate population by appropriate method to reduce the cancer mortality. Now another important topic, that is palliative care. So up to I'm just finishing it here. We will come back after a short break.